Good afternoon, everyone. My name is Dr. Rob Weissman. I'm professor of psychiatry and the chief of clinical services in our community division. It's my pleasure today to introduce the John Romano Rounds presenters to my right, and one will be joining us shortly, and there she is, right on cue. Dr. Mathis shows, and in the spirit of Dr. Romano, was busy taking care of a client, so appreciate what you've had to do to get here. Couple housekeeping events before I introduce our speakers. As everyone knows, this is both attended in person and in Zoom. For those of you who are on Zoom, please know that the QR will be posted so that at the end you can get your credit and apply for the credits that you deserve for attending this. That will be both posted up on the slides as well as on your Zoom. To get started here, we will have our presenters, and then at the end we'll have time for Q&A. For those of you on Zoom, you can present your questions if you have any on the chat section, and we'll be managing that at the end for the Q&A with our panelists. Today's Romano Rounds is especially important, I feel, as typically we present a clinical case or clinical situation and work through that. Today we have something that combines both the clinical acumen as well as educational programming that's been done and highlighted in Strong Recovery. The title of today's presentation is called Developing Our Workforce for a Brighter Tomorrow, Strong Recovery's Training and Education Program. This is a very unique program. It's taken some time to do, and the wonderful panelists here that I'll introduce now have been a part of the engine developing this. First off to my right is Julie Achtyl. Julie Achtyl is co-director of operations and director of counselor education at Strong Recovery Addiction Psychiatry Outpatient Clinic and the division chief of CASAC at the University of Rochester Department of Psychiatry. Julie has primary oversight of the Adolescent Young Adult Clinic, the Adult CD Clinic, Training and Education, and CCBHC Outreach Services. Julie is a licensed mental health counselor, credentialed alcoholism and substance abuse counselor, nationally certified counselor, and approved clinical supervisor. In 2017, Julie became a New York State certified trainer in Clinical Supervision Foundations 2 and has trained hundreds of supervisors across our state. Additionally, in 2020, Julie returned to her alma mater, the Warner School of Education, to pursue a PhD in counseling and counselor education. And she celebrates the halfway mark of her training enthusiastically, she shares. Julie blends her passion for counseling, clinical supervision, leadership, and teaching through training professionals and mentoring clinical staff and students. What we're going to hear about today is a product of all the work that Julie and her team has done and her work with the Warner School. Next, I'm going to introduce Dr. Gloria Baciewicz. To her right, Dr. Baciewicz has specialized in the treatment of substance use disorders since 1986. Dr. Baciewicz was medical director of Strong Recovery since 1992, retiring from that position in 2022. And I always joke with Dr. Baciewicz that she's retired, but she keeps coming back doing grand rounds and running grants and teaching folks. So retirement is not looking very easy these days. She is currently co-PI for the HRSA Health Resources and Service Administration Recovery Center of Excellence grant and continues to collaborate with Dr. Mathis with teaching needs through Strong Recovery. Next to Dr. Baciewicz is Dr. Myra Mathis. Dr. Mathis is the medical director for Strong Recovery UR Medicine's outpatient addiction psychiatry service, which includes opioid treatment program, adolescent and young adult clinic, and the SUD-PC, or substance use disorder in primary care service. She is also the program director for UR Medicine's Addiction Psychiatry Fellowship Program. Nationally, Dr. Mathis serves as co-chair for the Opioid Response Network's Black Communities Work Group, or the BCW. It's my pleasure to introduce the panel, and first to speak will be Dr. Baciewicz.
Thank you, Dr. Weissman. And it's great to be here in person and without masks. It's quite wonderful. So thanks for having us all today. We're excited to talk about our educational program. And our title is Developing Our Workforce for a Brighter Tomorrow. And you heard all about us and our learning objectives. Financial relationships, we have none. Okay, here we are. So we're going to talk about the history of Strong Recovery's training and educational program, workforce challenges that we have met with, need for expansion, yet again, advanced certificate program in addictions counseling, which Julie has been dealing with, and the addiction psychiatry fellowship, with which Dr. Mathis has applied for and gotten approved. But first, I thought that it would be good to talk about the why of this. They're going to talk about the how of this, but I want to talk about the why of this, and I also want to mention a couple of projects that are dear to my heart that I've been involved with for many years. So why is developing our workforce important? Deaths related to alcohol and drug use continue, and the need for what we do continues. Obviously, you've all heard about the overdose crisis, which has been continually getting a bit worse in recent years because of fentanyl. And now we have xylazine complicating the picture as well. Yet most of the deaths from opioid overdose are attributable to fentanyl. So this is a graph of unintentional injury done by the CDC. And what they're saying is that unintentional injury contributed to more years of potential life lost than any other cause of death in 2020. The overdose category is within unintentional injury. CDC puts overdoses under the top category there, which is poisoning. So in 2020, 1.97 million people died from poisoning, most of which was actual drug overdose. And most of the drug overdoses which have been fatal are opioid overdoses. Most of the opioid overdoses are actually fentanyl overdoses because there's very little heroin out on the street anymore. It's been replaced by mostly fentanyl. And on top of that, fentanyl is often cut into other drugs, such as pills, other powders, cocaine. It's added to a lot of stuff because it's very, very cheap. So it's a big concern out there. The other categories where you might see deaths from substance use disorder are the second category up there, motor vehicle traffic, DWI obviously, and driving while impaired from drugs as well. And then other injuries, especially falls, can be related to drug and alcohol use as well. So the estimated US economic cost of injuries in 2019 was 4.2 trillion. And more than half of this cost was on working. A big problem. And I'm sure you've probably all read that the male life expectancy has been trended downward because of so many deaths from opioid overdose, especially during COVID. Anyway, this is not only why we do what we do, we also do what we do because of the hope that we have for people to get better. It's really, a lot of people think of it as a dismal type of profession, dealing with substance use disorder, but actually we find a lot of hope and joy and pleasure in it, especially when people are able to turn their lives around. So the other The other couple of things I wanted to mention before we get into the other two speakers are one of our very important educational projects was the Patient Instructor Project. And maybe there are some people in this room who went through U of R medical school and got to do this in the third year. This consists of individual interviews of community participants who have been abstinent for many years, but are acting as if they are still using alcohol or drugs and have a medical problem connected to their use that they're seeing a doctor for in the exercise. Participants then give medical students individual feedback about their interviewing. And believe it or not, this was developed by my predecessor as medical director, Dr. Robert Klein, in the 1980s. And then when I came in 1992, I continued to do the project for, I don't know if it's 15 or 20 years or so. And then Dr. Steve Novak took over. And he is continuing to do this project. During COVID, he learned to do it under Zoom, but now they're back face-to-face, fortunately. So that's been something that I've often thought of as one of our flagship educational projects. It's a very interesting thing, and sometimes students are very surprised to find out that these are people who have really struggled with alcohol and drug problems. They are not just standardized patients, just random people who are doing it for the experience and the reimbursement. So here's our other long-term project, and this is not exactly a project for the workforce, but it is a project that we have educated a lot of people in since 2013. That's when we started it. And the oranges are up there because our first kit included actual syringes. Probably most of you know that naloxone spray, known as Narcan, is an intranasal spray now. We don't have to worry about giving injections anymore. But in the beginning, in 2013, the overdose crisis was heating up. So we decided to participate in this program and give people actual naloxone prevention kits that contained actual syringes. We brought oranges to the training so that people could practice with giving injections to oranges. Okay, and I think right now I turn this over to Dr. Mathis to talk about the administrative diagram.
Thank you, Dr. Baciewicz, who we affectionately refer to as our Medical Director Emeritus. This is just briefly to share about who we are as Strong Recovery and who contributes both to our clinical and educational missions. And as you can see, we have Medical Director, our co-directors of operations, of whom Julie is one, and she'll be speaking shortly. We have Associate Medical Directors that cover our adolescent and young adult services. We have clinical coordinators and supervisors to support our clinicians, in addition to our nurse manager and other nursing staff. And so we really wanted to give you a sense of who we are as Strong Recovery, a truly interdisciplinary and multidisciplinary and interprofessional program with individuals who bring a variety of diverse experiences to the work that we do on a day-to-day basis. And here are some of those faces behind that organizational chart. This is from our Strong Recovery program retreat held just a couple of months ago. Because of the size of our clinic, where we have over 80 staff members, we had split it over 2 days. And so this is us getting outside of the office a bit to enjoy some time of learning and connecting together. As we're thinking about what the future of Strong Recovery, the future of addiction psychiatry really looks like for UR Medicine, we're grappling with a lot of workforce challenges. And those workforce challenges are not unique to just strong recovery alone. So Julie is going to come and share a little bit about the context of the workforce challenges for substance use disorder treatment programs, as well as mental health programs, and some of the ways that we're grappling with that, continuing into how we're utilizing our education programs to ameliorate some of those challenges. Julie?
Thank you, Dr. Mathis. Okay, so I'm going to be talking briefly about a National Council for Mental Wellbeing survey that was released, and it focused on industry workforce shortages. And the information was actually released a couple of weeks ago. So I'm going to show some of the data points that really stood out to me. So this first one here, actually, before I get to this, I just also want to note that there were 750 mental health and substance use disorder employees that were surveyed across the country. So this is national data. So the respondents indicated that COVID-19 seemed to have a large impact on the increase in caseload size and also client severity. 65% of the respondents indicated some variation of severity. Notably, 34% acknowledged that their caseloads increased slightly, 30% increased significantly. Severity, 26% indicated that it increased significantly. And we've also seen this locally and at Strong Recovery. The pandemic, coupled with a multitude of regulatory and paradigm shifts, has really changed the way that we provide SUD treatment. Patients' needs and symptom severity has increased, yet they're coming to treatment less. So we have to be creative with engagement efforts within the SUD field. And when I say SUD, I mean substance use disorder. Next, the workforce shortages are causing nearly half to consider other options. So I just want to take a moment to read these questions that were posed in the survey. I do not want to leave the mental health and substance use disorder field, but it often feels like I have no other choice. 37% of respondents agreed somewhat with that statement. Additionally, the impacts of the workforce shortages have caused me to consider other employment options. 34% also agreed somewhat. And one thing that I think is really important to note about this is that there's a difference between organizational commitment and occupational commitment. Organizational commitment is when an individual has longevity where they're working, either their clinic or their agency. And that can be as a result of a multitude of factors. I personally believe it has a lot to do with the leadership, the culture, the supervision that a person is receiving, and their ability to connect with their colleagues and their peers. Occupational commitment is when someone remains in their occupation. So they may, over time, transition from one clinic to a different clinic, but they still remain as a substance use disorder therapist or mental health therapist, or even someone that works with someone with co-occurring disorders. So I wanted to show this slide because we refer to Strong Recovery as a family. Knowing people have a choice to leave the organization or the occupation altogether, we work hard to create a balance of work and fun. Here you'll see us coming together during Pride Month, of course, cheering on the Bills. We had a music session weekly where many of our talented staff members came together. I am not included in that. I did try to sing, but it really was not good. But then I had lovely Dr. Mathis and Tim Owens and some of our other staff that came together, and it was really a wonderful opportunity. And then we also created a breast cancer awareness walk, and these are just a really small sampling of the kind of camaraderie and coming together that we have at Strong Recovery. In 2012, and although this is an older study, researchers studied turnover in the substance use disorder field and found that counselors with greater perceived organizational support were 13.8% less likely to voluntarily leave over the next 3 years. A third of mental health and SUD employees spend a majority of their time on administrative tasks. So I want to take a moment here to stop and ask the group, when I say administrative tasks, what does that mean to you? Can you just throw out some ideas? What was that? Writing your notes. What? Treatment planning. Yep. Any others? Follow-up phone calls. Paperwork. Yes. All of the above. Absolutely. Documentation, case management, chart review, and supervision. So you feel like you're, as a therapist, you may be spending a lot of time doing that. The respondents in this national survey indicated, for example, that 17% of them felt like they were doing that for almost the entirety of their job. In supervision, that can bleed into supervision where you're discussing productivity, caseload management, audits. So for some people, it can feel like you're never getting away from that when you came into the field to be a therapist. So these administrative tasks are taking time away from client care, and for nearly half feels unnecessary. The questions that were asked: I am not able to manage the administrative demands of my job without working extra hours. The amount of time I spend on administrative tasks takes away from the time I could be directly supporting clients. I'd imagine many of us can relate to these statements, as well as these participants that also agreed or strongly agreed with these statements. So how do we support our staff through the less appealing parts of their job? I personally believe that leadership has a great influence, and we just start with talking to our staff, actually hearing what they have to say about the struggles that they're going through when it comes to administrative tasks. Just recently, I've been fielding additional or increasing concerns about the amount of time it takes our therapists to coordinate rides for our patients to get to our clinic for programming. And so I sent out an email to our staff and I asked them, give me all of what's going on. I want to hear how this is taking so much time. And they gave me so many specific examples of tasks that they're even repeatedly having to do. And so I'm taking that information, collaborating with the system, and trying to figure out how can we significantly reduce the amount of time on this administrative task that's causing great frustration. So I want to transition to some clinical supervision challenges and opportunities, because I believe that this is really where a lot of the most powerful and influential work happens in a substance use disorder and mental health clinic. So first of all, in substance use disorder, it's a common practice for a supervisor to have this dual role where they are tasked with spending so much time on administrative tasks and also hopefully clinical tasks, clinical supervisory tasks. However, these two buckets, they're very conflicting and they're challenging to execute both of them well. However, it is a common practice. And what I've found is that there truly is a propensity for a supervisor to want to spend more time in those administrative tasks. And I think that that's because there's been multi-generational lack of education and training because of requirements that are set at the state level. So, for example, and from the Office of Addiction Services and Supports, I believe that the way the job is designed, it leaves little time for clinical supervisory tasks. And an individual is learning a lot about how to be a supervisor through on-the-job training. And if their supervisor was never taught about clinical supervision, they're just training that individual on how to process and work through administrative tasks like productivity and caseload management, which really leads to role confusion. That therapist feels like, are you my supervisor? Am I supposed to come to you with vulnerabilities I may have about my growth as a therapist, or am I going to always feel like I'm being evaluated? So that can really challenge a therapist, and particularly if they're working with a complex patient, they may not feel comfortable disclosing vulnerabilities. Trust in the supervisory relationship is essential to professional development of therapists. And if they are always feeling evaluated, it reduces disclosure of vulnerabilities. And I want to note that in my time training supervisors across the state, I continuously hear that people are receiving little to no supervision. So this is a common occurrence that is taking place that I feel very strongly about advocating for change. Historically, the mental health field is structured through formal education. So states as a group have lower expectations for substance use disorder therapists. Few states require certification and/or licensure. And when it's required, it's at a lower minimum education degree than our mental health partners. So for example, a substance use disorder therapist, a bachelor's or lower is required. And for mental health, you have to have a master's degree. And then the supervisor has a master's degree. However, in the substance use disorder field, as a supervisor, you're only required to obtain a bachelor's degree. There's no specification of what type of bachelor's degree. Therefore, supervision theory is not being taught. How to actually execute clinical supervision is not being taught. You do have to obtain a CASAC and then complete the 30-hour clinical supervision foundations training that I do train, and it is an excellent training, but the requirement ends there. Strong recovery requires 5 years of combined clinical and/or supervisory experience to be a supervisor, a master's degree, and a CASAC. So we are superseding what the state requires to be a clinical supervisor. And I question, do these efforts contribute to longevity? I'm incredibly proud to present on some longevity averages. So at Strong Recovery, our clinical supervisors, our clinical coordinators, and our directors, our longevity average is 14 years at Strong Recovery. Our operations team, which their longevity average is 11 years. Our clinical staff longevity is 7 years, ranging from 1 year to 33 years. And I'd like to take a moment to recognize the infamous Charles Brown. Percent of our CASAC, 98% of our team has a CASAC. There's one individual that has a CASAC-T. Our percent of clinical licensure, 41% have a clinical licensure. 16 out of 39 individuals have an LMHC, an LMSW, or an LCAT. 5%, or 2 out of 39, are limited permit. An internal promotion. Out of the 14 people that serve on our leadership and operations team, 12 out of those 14 have been internally promoted at Strong Recovery, 2 of which have joined our team from an external clinic. So we can only hypothesize what contributes to longevity at Strong Recovery and creates value for our staff. However, we feel confident that the training and education requirements of our staff and then opportunities provided to them as a Strong Recovery employee, coupled with a passion for quality supervision, contributes to organizational commitment. So then it helps us to create this goal to gain an understanding of the training and educational needs of our diverse staff and support these goals through transformative clinical supervision and professionalization opportunities. So getting to our training and education expansion. So we've kind of set up the argument for why it's so important to be able to create opportunities within Strong Recovery, because sometimes the support could be lacking from the state entities. So what can we do within our own power and control? So we've created an educational series that I'm going to talk about briefly. Internship programming that with our affiliate schools, we bring in people in a bachelor's program, master's program. Recently, we've just been able to figure out how to have a PhD student do an internship. And our marriage and family program, we have their student trainees come in for some observation as well. We do licensure supervision. We supervise people that are hoping to obtain their licensure, both in individual supervision and group supervision. Dr. Mathis will talk about our addiction psychiatry fellowship. Dr. Baciewicz talked about our patient instructors. Annually, we put on a Joseph Ryan conference. I'll be talking about our advanced certificate program in addictions. We have a robust solution focused training. And then we have an academic council where we all come together to try to keep all of this organized. This is some pictures from our solution-focused clinical supervision and train the trainer program. Dan Lawson is a solution-focused expert, and he's the guy up there in the flannel. And we have a monthly training to learn about the tenets of solution-focused the approach. Participants are clinical staff and leadership. They set the expectation together that they will practice this approach with patients and together in supervision. Our goal is to work towards a culture shift that moves away from problem-based language and towards solution-first language. Our educational committee comes together and they identify needs, interests, and topics from our staff to increase knowledge on substance use-related issues. In response to identified interests and needs, the educational committee coordinates and collaborates with staff in this clinic and other agencies in the community trainings to enhance knowledge on substance use disorders to better serve our population. And for someone that has a CASAC, they have to renew triennially. So in those 3 years, you have to obtain 60 continuing education credits. And if someone at Strong Recovery were to attend every single educational series, they would accumulate 54 continuing education hours and basically have all of this for free, which is a wonderful opportunity for our staff. Additionally, we were recently approved to be an LMHC training provider. So we are also offering LMHC credits, and we will be working on social work credits as well. This is just a sampling of some of our trainings that we held in 2022. And some titles are Advancing Health Equity and Addiction Treatment, The Comorbidity Between ADHD and Substance Use, Common Myths, Introduction to the Safe Side Framework, Eating Disorders and the Effect that Eating Disorder Behavior Has on Human Physiology. Okay, so moving on to our Advanced Certificate Program in Addictions Counseling. This has been a collaboration between Strong Recovery and the Warner School for 4 years. The pandemic did put us behind a little bit. However, we are finally at the point where we are ready to get this program off the ground. We believe that this enhances our education efforts by partnering and creating an opportunity for master's prepared professionals. I would just like to take a moment to thank Dr. McGinnis, Dr. Jafrida, Dr. Mackey, and Patrick Setch for all of your efforts and persistence in creating this program. So this is Dr. Karen Mackey, and she was supposed to join us today, but she was unable to. Dr. Mackey and myself are the co-directors of this program, and she just had some words that she wanted me to share about the program. So she believes that providing coursework and experience attending to the mental health concerns and psychotherapy interventions that are responsive for these, for addiction and healthcare professionals seems like the next good opportunity for cross-training to enhance the care delivered to patients. Oh, sorry. Oops, wrong button. Oh boy, I don't know how to go below this. All right, so we've really taken pride in making sure all our students get the 350 hours of addiction education embedded to their program coursework, making them eligible to go further with addiction certifications should that prove a fit. Similarly, providing coursework and experience attending to mental health concerns and the psychotherapy interventions that are responsive to these for addiction and healthcare professionals seems like the next step for the addiction certification program. So our advanced certificate program in addictions, the rationale for this is it creates professional and teaching opportunities and recruits new staff and retains current staff. It's really unique because it's specialized for master's prepared clinical and nursing professionals in the human services. The intended audience is for people that have a master's degree because commonly they will submit their training or their transcript and other information, and the common deficiencies are in what's called Section 1 and Section 2. 85 hours in Section 1, 15 hours of ethics in Section 2. So with both of that, we have combined these 100 hours and created courses that are tailored to the specific needs of these individuals. The length of the program is 2 semesters. It's going to be starting in the fall, and classes are generally after work hours, starting at around 5 o'clock. There's also going to be flexible internship opportunities. So some points of differentiation. How do we stand apart? First of all, our partnership between Strong Recovery and the Warner program. The courses and the internship, a seamless transition from Warner to Strong Recovery to complete internship hours. Faculty and expertise. There is many, many, many years of expertise on both the Warner faculty and the Strong Recovery staff and faculty that will be teaching these courses. And there are two tracks, the supervision track and the internship track. So as you can see here, the addiction psychiatry side of the house, we will be teaching the advanced substance use course, contemporary trends in substance use course, and we have the internship site. The Warner School will be teaching the advanced ethics, counselor internship course, and counselor supervision. So the first track is the internship track. This is for an individual who may want more experience working with people that have substance use disorder. So they would attend these courses and then also attend the internship course and complete their internship at Strong Recovery. If someone has already had a lot of experience in substance use disorder and they're interested in furthering their career as a supervisor, which in my experience, there is not nearly enough formalized graduate education opportunities and experiences for individuals that are seeking to advance their career and become a supervisor, they can join the supervision track, take these courses, not do an internship, and complete the doctoral level counselor supervision course. And lastly, I am thrilled to unveil our marketing. So this is our flyer that I am happy to send around anyone who is interested. This is also my shameless plug that we need 6 students to start our program in the fall. And I'm really hoping that we're able to find some interested people that are looking to become a CASAC. It's really rather marketable to have a license and the CASAC or credential. And I appreciate your time, and I'm going to transition to Dr. Mathis, and I'm also happy to answer any questions after this that more about the program. So thank you.
Thank you, Julie. So I'm going to speak briefly about first the need for addiction psychiatrists and what we're doing at Strong Recovery and within our department to grow our faculty and physician base in addiction psychiatry. So 20% of all patients with psychiatric illness have comorbid substance use disorders. For those of us in the Department of Psychiatry, 1 out of every 5 of the patients that we see has a substance use disorder. It's one of the highest degrees of comorbidity in psychiatry. And for residency training, the degree of comorbidity does not match the degree of education that is required at an ACGME level. 90% of patients with both psychiatric and substance use disorders do not receive treatment for either. Some of this is related to engagement, right? And challenges related to engagement when you have co-occurring disorders. And some of this is about where someone can receive treatment and whether or not the professionals that are ready to meet them are trained to address both of their needs. As Dr. Baciewicz mentioned at the beginning, the overdose crisis continues. The death, the morbidity and mortality related to substance use is only increasing. And so we really do need to increase our capacity to meet the clinical, educational, and scholarships demands related to substance use disorder treatment within our medical center and our region. As currently, we only have 2 board-certified addiction psychiatrists in Monroe County and the surrounding counties. Those 2 individuals happen to be in this room right now. So we really need more of us in the workforce. In terms of the education opportunities that are provided for medical providers and professionals. So prior to the development of the Addiction Psychiatry Fellowship, Dr. Baciewicz collaborated with Toxicology Service to develop a non-ACGME departmental fellowship in addiction medicine. So individuals completing this fellowship experience were able to sit for the addiction medicine boards, and many of our faculty within our addiction psychiatry division have also completed this process. Our PGY2 psychiatry resident rotation for 4 weeks. It's nice to see some of our residents in the room. PGY3 and 4 psychiatry special electives for residents, where they might have more focus on prescribing medications for addiction treatment. We also host psych NP and PA students. We host adolescent medicine fellows. We host child and adolescent Psychiatry Fellows. And for medical students, we have elective experiences and the patient instructor program that was already spoken about. And as Julie mentioned, the longevity of our staff members, we didn't specifically talk about staff who have trained in some capacity at Strong Recovery and then continued as ongoing staff members, Julie being one of those individuals who started out as an intern at Strong Recovery. And I like to say that my Strong Recovery origin story is in the patient instructor program as a third-year medical student here at the University of Rochester. So for the Addiction Psychiatry Fellowship, our goals are to train highly skilled addiction psychiatrists who advance successful careers in clinical, educational, and research environments. There is a huge need, and the need is only growing. We want to recruit fellows who can fill this critical workforce need after program completion. And we want to make sure that our fellowship program and the ongoing leadership of Strong Recovery continue to be racially and culturally diverse to provide culturally informed and structurally competent care to our diverse patient base. In terms of our program and our faculty, so we have both addiction psychiatry and addiction medicine boarded faculty that come from a diverse array of training backgrounds. We have general adult psychiatrists, child and adolescent psychiatrists, a family medicine physician, a dual trained pain and addiction psychiatrist, med psych physicians, and toxicologists who contribute to our teaching faculty for the fellowship. In addition to our faculty, participants in the Addiction Psychiatry Fellowship, I am looking at you, residents. Future Addiction Psychiatry Fellowship participants will also work with a multidisciplinary team, which includes medical and psychiatric nurse practitioners, our addiction counselors or CASACs, mental health therapists, family specialists, psych and vocational rehab specialists, case managers, and certified peer specialists. Again, we're very proud of the multidisciplinary team. And I should also, of course, mention our skilled and talented nursing staff who participates and contributes in such meaningful ways to the work we do at Strong Recovery. Our trainees will receive a robust and well-rounded clinical experience in addiction psychiatry that features a hospital-based opioid treatment program. There are very few addiction psychiatry fellowships that have an in-house opioid treatment program within which fellows are able to gain additional experience in prescribing and management of methadone. Rapid access buprenorphine program, nursing injection clinics for both naltrexone or Vivitrol and for Sublocade. The Substance Use Disorder and Primary Care Service, which is a mobile primary care consultation team, our adolescent and young adult services, an inpatient addiction medicine service, an inpatient addiction consult service, and a criminal legal system treatment and access programs. So really, we provide a breadth of training opportunities, even within our programming at Strong Recovery, and individuals who train with us will be well prepared to meet the needs and the demands of addiction treatment from a medical perspective. And so in summary, as we have shared about some of the work we're doing internally in Strong Recovery, really what we've done is take you through a journey where we've talked about and thought about our internal culture, what we're doing internally at Strong Recovery to support our staff and our clinicians, both from the standpoint of wellness and community building, but also from a supervision and education perspective. We want to take that internal culture and infuse it into our expanding new educational programs, including the Advanced Certificate Program and our Addiction Psychiatry Fellowship. And we hope that in doing so, we will meet present and future workforce and clinical needs in addiction treatment by growing our staff and faculty base. So thank you all again for your time, for listening to us talk about our passion projects that we've been working on over the last few years, and we will take questions.
The button right there, just push it up.
Well, thanks all of the presenters. Great thanks to the presenters here. What a wonderful presentation that opens our eyes to the challenges, but how to fix these challenges. We scratch our heads trying to get our workforce, I think, level set and to deal with the challenges, particularly with the comorbidity numbers we see, and in some cases even higher, right, that require expertise. As we close, I just again invite people that are on Zoom to enter any questions, thoughts on their chat. And presented here is the QR code in order to do your survey and get credit. In waiting for some points and questions to be posed, I had a couple just teed up, and I always look at things a bit half empty and say, where are the challenges even with the greatest programs, and how do we work around that? And I'm sure our wonderful panelists have thought about this. A couple things come to mind for me with the collaborative program with the Warner School and Strong Recovery. Is there a way, other than how good the program is and how inviting your staff are at Strong Recovery, to incentivize those students to come and work there, to avoid brain drain, if you will, to other agencies as you described earlier? And if you want to respond, maybe just turn on your mic. I don't know if they're on. You just pull that little lever up.
Got it. I think I got, but I'm also very loud. Okay. So I think that Strong Recovery not only has so much to offer a person that is looking to advance their career. So part of the goal in collaborating between Strong Recovery and Warner is to create a program that really highlights the value and importance of education and streamlining to an organization that truly prides ourselves on our ability to train people that are working to reach their educational goals. So then really the passion behind that, to make sure that when someone comes to an internship with us, that they leave ready to step into their own role. We oftentimes will hire interns into Strong Recovery because we know that they are ready to hit the ground running, because the internship programming that we create for our students is incredibly robust. They're going to learn everything that we do at Strong Recovery, everything that's expected of them before they sign the dotted line to become an employee of the U of R. So in that way, I think that it's really, what am I trying to say here? Like, I just think that
built in.
Yeah, like it's built in, the system that we have built, it's very attractive to an individual, not only to come to Strong Recovery because of the opportunities we can provide them for their professional growth, but then also for current employees if they want to expand their learning. What we also find is that people that come and interview for us, they have a master's degree, they have years of working in the substance use disorder field, but no one ever encouraged them to get a CASAC. And the CASAC requires 350 educational hours that's specific to understanding the nuances with treating someone with substance use disorder. And if you don't have a CASAC, then you're really missing out on a lot of that important education. So being able to even hire someone with a master's degree that doesn't have a CASAC, this is a wonderful opportunity for them to go through a one-year program and be able to obtain that information from individuals that have been working in this field for decades.
Excellent. Thank you, Julie.
You're welcome.
Anyone else on the panel want to comment on that before I take the next point? Great. Dr. Nazra, your hand is up.
Thank you. Thank you for this wonderful presentation. As we all know, substance use disorders do not occur in a silo or in a vacuum. And I want to commend you on work you're already doing with other divisions, with primary care, with the region as a whole around this. Can you talk a little bit more about your collaboration with community-based organizations that provide peer support or housing or anything like that?
I will start, but I'm also going to pass this one to Julie as well, since she primarily supervises our outreach team. So one of the primary ways that we can collaborate with community-based organizations is by being a CCBHC, in that it allows us to expand our services through case management, peer support, psych and vocational rehab therapists that really can meet our clients in the community. Our psych and vocational rehab therapists go with our patients to appointments, help to coordinate those appointments. And so that they are a link and a bridge in many ways in collaborating with community-based partners. Our peers as well can facilitate those connections, in particular when we're trying to get someone engaged at a higher level of care. Our peers even transport patients from our program to their inpatient bed, for example. And so they're really an extension of what we do at Strong Recovery and help us make those linkages more formal.
And I want to add something too, that we've also had a very special relationship with Norris Clinic, the addiction treatment center in Rochester. There are 11 of these addiction treatment centers in New York State. And together with Norris Clinic staff, we've been able to develop a program where people can actually not only continue the methadone that they're already on, but start on methadone if they need to start on methadone. And that sounds very simple. But it was huge in the system. It was something that was just not done in very many places. And now most of the New York State ATC system does it. So we're very happy with that. It helps us not lose patients going from one place to another.
I just want to add too, I think it's vitally important to have the right people in the right roles, and our outreach supervisor is top notch. He figures out every unique and creative opportunity to grow our outreach team and bring resources into Strong Recovery for our patients, but then also figure out how can we connect out into the community. And he has been instrumental in creating programming for our patients that our outreach team, he just does an incredible job of inspiring and motivating the team to grow and think outside of the four walls. I think that's what's been so incredible about CCBHC is that we're finally able to go outside of our four walls and be able to provide services to our patients where they're at. So thank you.
Great. A couple questions coming from, and then Patrick, I'll get you. Want to alternate a Zoom point in question from Dr. Tzipora Rosenberg, both a comment and a question. What an absolute gift to see a passion project that encompasses such clear values in wellness, retention, interprofessionalism, and excellence across domains of care. I'm especially heartened by the focus on staff development and education. A whole range of offerings from CE to certificate program and GME training. Can you say more about clinicians that see themselves as part of the educational mission while not detracting from what otherwise might feel like a heavy clinical mission focus, i.e. clinicians and staff being teachers to all of us?
Absolutely. Thank you, Tzipora. As always, very eloquent. So I was very mindful of that as I was looking ahead at this year and the amount of training opportunities that we were bringing to our staff. I didn't want to overburden them, recognizing how busy and challenging their roles are, how much time is spent to deliver the highest quality of care to our patients. So I really approach it from a needs-based approach. What are our therapists' goals? What are they looking to, how are they looking to grow themselves? And where are their interests? So with the solution focus, for example, I started small. I had Dan come in, it piqued a lot of interests. And then I asked people who would be interested in having him come back. Let's do a 2.0 with Dan and solution focus. Who wants to become more of a train the trainer? So it's based off of choice. And I think it's really important to combine leadership and our clinicians so that they see that we are on this mission together and that we're working to shift our culture together. So, and then two, we also are doing the safe side training. And I wanted to make sure that was spaced out. We also just completed an incredible trauma training. So there was a lot that was going on, and I wanted to make sure I was aware of the amount of time being spent and make sure that it's sectioned out in a way that people feel like it's manageable, but that they're learning something from it rather than it feeling like a burden.
Patrick Sesh.
Thanks, Rob. Wonderful presentation, by the way. For the partnership program, the certificate program you have with Warner, you mentioned you're looking for 6 students for fall 23. What's the maximum number of students the program can support? So beyond fall 23, how many students can be in the program and how many can do an internship, at
Thank you, Patrick, for your question. So we've talked about 10 being the max, because what we also have to consider, and that could fluctuate based off of the student's interest. If they're interested in the supervision track, then they wouldn't need the internship at Strong Recovery. So we may be able to take more students, but we have to be mindful of the amount of staff that are willing to take on an intern. And if the most interns we've had at Strong Recovery at one time was 10, and that was a lot to manage, but we figured it out. So I think 10 is our sweet spot right now, but that can be adjusted as the program grows and we learn more about the need.
Excellent. We have another point in question on the Zoom from Dr. Eric Kane. Dr. Kane says it is gratifying to see the continuing growth of addiction psychiatry, given the percent of patients with comorbid presentations, which is especially high in inpatient settings. How much more training do psychiatry residents need to be sufficiently trained for real-world work?
Like giving Suboxone, you mean, buprenorphine?
Yeah.
Yeah. That's a big concern of ours, because now that buprenorphine can be prescribed by any physician or nurse practitioner or physician's assistant, the trick is to get them to do that. So I think that's going to be a work in progress.
So excellent question, Dr. Kane, and really appreciate that. And actually, within the addiction psychiatry sort of education community, there are lots of thoughts about that. A paper published in Academic Psychiatry in 2022 by members of the ADPERD, our training organization, Addiction Psychiatry Committee, really outlined what additional training needs would be necessary for general psychiatry residents. And it includes expanding both our didactic, but also our clinical offerings. Right now, the DEA is saying a minimum of 8 hours of education, but 8 hours is not enough to really have the breadth of knowledge that is needed to meet the needs of patients with substance use disorder. So certainly more than 4 weeks, and with a more varied and robust didactic experience, for sure.
I think it's also a nice campaign for people to do the fellowship, right?
I couldn't have said it better myself.
I think we have time for one more.
Mine is super fast. On the note of this 8-hour training program, I know that I have to do that, and I want to do something that's actually meaningful.
Yes.
I work with primarily kids and adolescents. Do you have recommendations for what I spend those 8 hours on in a meaningful way?
Yes. So a wonderful resource, well, there are a few that you can consider, and I know that the state medical board has sent out some options. I would highly recommend some of the ASAM training courses, and you can filter that out by child and adolescent. Some of those do, if you're not a member, you may have to pay. However, there is a free alternative that's actually made possible by a grant held by the American Academy of Addiction Psychiatry, and that is the Provider Clinical Services Support, or PSSnow.org. You create a profile, but it is for free. They do have webinars and on-demand educational experiences that talk about child and adolescent population, a variety of population-specific education in addiction treatment. So enjoy.
Great. Any other points or questions before we close? Well, I just want to thank a wonderful presentation by all our panel members, and a big hand for all of them. And thanks for all folks, Steve Fasone, company interpreters, and all that were involved here. So have a good day, folks.